Welcome to the North Carolina State Medical Response System Initial Training Program for the State Medical Assistance Team. This presentation covers Module 1, an overview and history of the SMAT program. This module has 7 objectives, which include discuss the North Carolina State Medical Response System, or SMRS, discuss the role of the Office of Emergency Services, or OEMS, describe the North Carolina State Medical Assistance Team, or SMAT, the types, pertinent registries, and field operation, describe the legal, regulatory, and ethical issues impacting SMAT field operations and personnel duties, identify SMAT healthcare infrastructure, key components, planning, roles, and responsibilities. To begin, we should first understand the mission of the State Medical Response System, which is to ensure the delivery of healthcare services that protect the health and well-being of the residents and guests of North Carolina before, during, and after events that may overwhelm the healthcare system. The initial partners in the development of the North Carolina State Medical Response System were the North Carolina Department of Health and Human Services, or DHHS, the North Carolina Division of Emergency Management, or NCEM, the North Carolina Division of Public Health, and the Special Operations Response Team, or SORT. The initial model was based on a tiered design that allowed for a scalable response, similar to the Federal National Disaster Medical System, or NDMS. The concept of the SMAT was based on the Disaster Medical Assistance Teams, which are a part of NDMS. It's also important to mention that while these were the initial developing partners, there were many contributors from across many North Carolina organizations that helped with the development of the SMRS. These included the trauma regions, hospitals, several EMS agencies, and many other departments. Planning at all levels, from local, regional, state, and federal, is necessary to meet the needs and demands a disaster imposes on a location. It is not so much the plan itself, but rather the planning process that brings all the community elements together to work toward a common goal that is the core value in this process. All elements of the community healthcare infrastructure have an important role in disaster response and must be involved in the process. By convention, it is a necessity that all healthcare facilities, public health services, and mental behavioral facilities and entities have an emergency response plan. It must be regularly updated and accessible to all relevant agencies and personnel. Training and exercises that focus on activation and implementation of these plans are also important. North Carolina Regional Emergency Support Function 8 response and recovery plans have just been developed for all regions and serve as a valuable planning document and resource material. An operational definition of disaster is when the healthcare needs exceed the available resources of the healthcare infrastructure. As seen in several past disasters, notably the events of September 11, 2001, and the major hurricanes that have affected our Gulf Coast and eastern seaboard, healthcare and public health resources and systems may be quickly overwhelmed either by the direct impact of the event and loss of infrastructure or the sheer volume of casualties requesting services. Medical supplies may be limited due to damage and loss of infrastructure. Pharmaceuticals, consumable medical supplies, and durable medical equipment will be in short supply due to the fact that today's economy demands that healthcare facilities maintain only a small inventory to handle their day-to-day short-term patient loads. Dependent on the nature of the event itself, there are also may be demands for specialized medications, medical equipment, immunizations, and or mental health interventions. This increased demand in services and supplies will necessitate the involvement of the entire spectrum of healthcare, public health, and mental health care. The healthcare infrastructure is responsible for coordinating several roles and responsibilities and to provide oversight of operations in the following areas. First is mitigation. This involves evaluating the community or jurisdiction for threats utilizing the hazard vulnerability analysis and seeking strategies, plans, and projects that would lessen the impacts of that hazard on the jurisdiction. Included in this is the participation and facilitation of the jurisdictional planning process, training, and the conduction of exercises to evaluate those plans. The next area is preparedness. This involves activities specific for the health sector to prepare for a disaster. This would include planning, the development of protocols to be used in the field, training in the use of equipment, and many other activities to ensure that an organization is capable to function properly during an emergency. Your participation in this course is an example of a preparedness activity. The next area of importance is response. During response, the healthcare infrastructure is responsible for assigning and sending forth elements to do initial damage surveys and formulate the elements of the agency's personnel, equipment, and supplies that are needed to effect the initial stabilization of the impacted area and rescue of the victims affected. This would include activating or enlisting the ESF-8 component of the North Carolina Emergency Management Plan to provide assessment of medical needs, provision of medical care personnel, provision of medical equipment and supplies, coordination and assistance for transportation of medical supplies, coordination assistance for transportation of personnel, coordination assistance for evacuation of patients, provision of emergency responder health and safety, provision of medical command and control, and provision of emergency medical services. The final phase is recovery. Utilizing the information gathered from the initial damage survey and subsequent scene surveys, the coordinator will assist in the formation and coordination of the local, regional, state, and federal programs and assets that will begin the recovery process for the short-term, mid-term, and long-term establishment of the affected area. This may include management of grant programs to bring the community back to the pre-disaster level of function. The Regional Response and Recovery Coordinator is responsible for coordinating and providing guidance in these 4 areas. The mitigation, preparedness, response, and recovery efforts require a large number of personnel and agency prioritization to be effectively operational. This coordinator is the central point for this integration and provides for emergency management coordination of these important phases. Following the September 11, 2001 attacks, a sense of urgency produced additional funding resources that promoted the rapid development of state medical response capacity. Originally, the 8 Trauma Regional Advisory Committees, or RACs, were chosen for implementation of key components of the state medical response system because of each RAC's geographic orientation and medical capabilities. The lead RAC hospitals provided trauma education and served as the coordinating entity for trauma care in each region. In 2002, the SMRS developed a system of State Medical Assistance Teams, or SMAT. Clinical considerations for patients included the consequences of bioterrorism and weapons of mass destruction. Recognizing the need to increase medical search capacity, local, regional, and state agencies in North Carolina concentrated their efforts on developing this important emergency response capacity. Today, each SMAT is still geographically aligned with a specific RAC. However, most of them have formed separate healthcare preparedness coalitions and are no longer dependent on the trauma program for administrative support. One of the primary missions of the Healthcare Coalition is coordination of regional disaster planning between hospitals, EMS, public health, emergency management, long-term care, and other agencies. Prior to 2012, the SMRS program was supported by the Federal Health Resources Services Administration, or HRSA, grant program, as well as by the Metropolitan Medical Response System grant. The primary focus of this process was to fill gaps in disaster response resources and training, especially for responding to biological and chemical weapons attacks. Most of the original SMRS and SMAT equipment, resources, and vehicles were purchased with this funding. In 2012, the funding stream changed to the Department of Health and Human Services Assistant Secretary for Preparedness and Response Hospital Preparedness Program grant. ASPR is the same program that administers the National Disaster Medical System and the Disaster Medical Assistance Teams, or DMATs, which the SMAT program was modeled after. The ASPR HPP grant uses a focused capability approach to aid in planning for areas such as healthcare system preparedness and recovery, medical surge, emergency coordination and information sharing, and volunteer management. Funding from this program has been used to improve resiliency of healthcare infrastructure by supporting planning, education, training, and exercise initiatives on the local, regional, and state level. It has also been used to build out and further support the resource needs of the state medical response system. The framework for the SMAT program focused on the development of hospital, EMS, and fire-based teams capable of providing medical decontamination, medical triage, emergency medical treatment, and medical surge capacity in hospital and field settings. This framework identified 3 tiers of SMATs. These tiers were identified as the SMAT 1, SMAT 2, and SMAT 3. The SMAT 1 was initially modeled after the federal-based Disaster Medical Assistance Team, or DMAT, that was initially based with the Special Operations Response Team, or SORT, in Winston-Salem, North Carolina. SMAT 2s were deployed in each trauma region. Their mission was to provide rapid mass casualty treatment and management services during human-made or natural disasters. SMAT 3s were deployed by county EMS systems and the Charlotte Fire Department with decontamination and triage capability. The resources of the SMRS and SMAT were integrated into the State Emergency Response Team, or CERT, to provide early assessment and liaison with federal, state, and local authorities involved with the Emergency Support Function 8 response. The ESF system, or Emergency Support Functions, will be discussed a little bit later in this program and are also found in your National Incident Management System training. SMRS Tiered Response System was designed to ensure that both treatment and prevention strategies are implemented. The goal of this effort is to assure North Carolina residents and visitors that, when a disaster occurs, they will receive the medical services they need to protect their health and prevent the further spread of disease. Integral to the SMRS are 4 tiers of emergency response teams. These include the immediate response provided by ambulance strike teams and mass casualty buses, and then the SMAT 3, 2, and 1 typed resources. North Carolina has implemented an ambulance strike team program to provide rapid mutual aid response to any part of the state within a short period of time. The primary goal of the ambulance strike team program is to be able to draw from on-duty resources without causing a burden on the agency supplying the crew and ambulance. This is done by asking for 1 ambulance each from 5 different counties or agencies within a specific region. The strike team also comes with a supervisor in a quick response vehicle and a logistics support trailer. This allows the ambulance strike team to be self-sufficient for up to 3 days if need be. There are also 11 mass casualty ambulance buses strategically located around North Carolina. These are all operationalized by local EMS agencies so that they can respond 24 hours a day. Each bus has the capacity to transport 18 patients lying on stretchers. Some of the buses have the capability to transport wheelchair patients as well, or can be converted to provide responder rehab at large events. The optimal patient for these buses are those that only require a basic life support level of care, or those that have been triaged as green or low priority. SMAT 3s are tasked with the following capabilities: provision of medical treatment and triage, assistance at hospitals, provision of rapid victim decontamination, provision of responder treatment and rehab. At a minimum, each team should consist of at least 7 members during a deployment. At a minimum, there must be at least 1 paramedic and 6 EMTs or higher on each deployment. Each team should be trained 3 deep for each position to provide 3 complete shifts. Other medical professionals and support staff may be added to support the team's mission and operation. SMAT 3s can be activated on a local, regional, or statewide level. Response time is mission specific and is expected to be 1 to 6 hours from the time of notification. There are currently 29 SMAT 3 programs distributed across the state. While the original primary mission of the SMAT 3s was to perform mass triage and decontamination, the state has recently started looking at how to modify that mission and equipment to allow teams to specialize in other areas. Some of these areas include special event support, responder rehab for large events or technical teams like USAR and HAZMAT, wildland fire support, and several others. Adjusting some of the mission types will allow each program and the state to be able to better leverage the personnel and resources dedicated to the SMAT 3 program. The SMAT 2 program was designed to support the continuity of healthcare infrastructure across the state during daily operations, planned events, or during disasters. This includes primary and secondary missions that can be tailored to assist hospitals, EMS, long-term care, public health, and others. The primary missions include the larger tasks of establishment of state medical support shelters, field aid stations, or alternative care sites. This also includes the more common and smaller task of providing logistics support to our regional partners with single items or smaller caches of equipment. The secondary missions include providing support to points of dispensing or isolation and quarantine operations in partnership with public health. We also have the ability to help our hospital partners with training and resource support for their decontamination programs. An SMAT 2 has a standardized mobile package that includes basic medical equipment and sheltering for response. This hospital-based team consists of both medical and non-medical members. Doctors, physician's assistants, nurse practitioners, nurses, paramedics, and EMTs make up a large majority of most teams. However, many teams also actively recruit pharmacists, mental health professionals, public health professionals, interpreters, and other support staff, commonly found in a hospital. However, it is important to mention that many teams heavily rely on their non-medical members as well. These members provide important services like communications and IT infrastructure, vehicle operation and maintenance, and other logistical, administrative, or support functions necessary for the team to be operational. It is also important to note that the SMATs seek volunteers from all of the hospitals, other medical agencies, and any other source available in their region. In terms of activation, an SMAT 2 can be activated on a local, regional, or statewide level. Response times should be 6 hours for something within the local region, 12 to 24 hours for something within the state. This map identifies the 8 healthcare coalitions and shows the location of each of the 8 SMAT 2 programs. In general, state medical support shelter support begins at the local level and transitions to state and federal levels when the capacity to respond at the previous level has been exceeded. It also addresses challenges associated with the care of medical needs patients during a disaster through the location and registration of these citizens before an event. Patients with functional medical needs include people with minor health or medical conditions that require observation, assessment, and maintenance that exceeds the capacity of the congregated shelter staff. Also included are people with chronic conditions who require assistance with activities of daily living or who need more skilled non-acute nursing care but do not require hospitalization. The State Medical Support Shelter is modeled after a federal concept known as the Federal Medical Support Shelter. The FMSS concept of operations includes beds, supplies, and medicine to treat 250 people for up to 3 days. The FMSS includes base medical support, treatment, and a pharmacy. Each region has supplies that include 80 beds, basic pharmacy and treatment supplies, and is designed to augment more robust mobile or fixed medical facilities. The SMSS equipment cache is contained within a tag-along trailer and a 48-foot refrigerated trailer. The SMSS staffing is generally focused on chronic health problems or minimally acute medical needs. These resources are typically coordinated by the ESF 8 lead, or North Carolina Office of EMS, and may be used either as a standalone or in support of other similar or complementary assets. The SMSS needs to be housed in an indoor location. Locations may include, but are not exclusive of, gymnasiums, unoccupied fixed facilities, or other hardened structures. The typical footprint of this type of shelter is a 3,000 square foot enclosed climate-controlled space. Additional needs include support services like communications, information technology, food and water, waste disposal, medical oxygen, laundry, refrigeration, and controlled substance storage, bathroom and shower capability, and security. Each of the 8 healthcare coalitions also maintains the infrastructure to establish a field aid station that can be used for providing initial stabilization of patients who need care in an austere environment where a fixed facility is not available. The Field Aid Station is a tent-based facility built around the Western Shelter GK 1935 tent system. Each team has at least 6 tents that can be connected to provide 36 to 40 beds. Or multiple teams can come together to make a larger base camp. The system also includes options for heat and air, heated water, sinks, showers, and bathroom facilities. The other critical component of the Field Aid Station is the M8 trailer. In addition to transporting the infrastructure components, it also provides a small command or communications center, an 80 or 110 kW generator for site power, and the cargo area can be converted into an air-conditioned sleeping area for staff. Many teams have deployed their field aid stations in varying capacities over the years for local or special events or planned events to test the functional capability of the resource. Up to this point, we have discussed the SMAT 3 and SMAT 2 resource types, and the SMRS tiered response references an SMAT 1. While there is no longer a personnel component associated with a Type 1 team, North Carolina does maintain a large medical continuity of operations asset called the Mobile Disaster Hospital. This asset was originally assembled by FEMA as a federal medical response resource. In 2009, FEMA agreed to transfer ownership of the asset to North Carolina as FEMA transitioned out of the medical response business. The resource can generally be deployed within 24 to 48 hours after activation, and operational within 48 to 72 hours after arrival. The resources are available to North Carolina, the southeastern United States, and then within the continental United States. The resource includes 2 5-bed mobile emergency department trailers, a tent-based 21-bed emergency department with X-ray, lab, pharmacy, medical supply, and logistics support, a 12-bed ICU built from modular structures, and an operating suite. In addition to recruiting from our regional hospitals, EMS agencies, and other partners, the SMRS also includes volunteers that come into the program from the Medical Reserve Corps. From the Medical Reserve Corps website, the MRC is a network of community-based units initiated and established by local organizations to meet the public health needs of their communities. It is sponsored by the Office of the Surgeon General of the United States. It was founded after President Bush's 2002 State of the Union address, in which he asked all Americans to volunteer in support of their country. The MRC consists of medical and non-medical volunteers such as medical and public health professionals, as well as other community members who may fill support positions. These volunteers may contribute to local health initiatives such as activities meeting the Office of the Surgeon General priorities for public health and supplement existing response capabilities in times of emergency. The MRC is a partner program of Citizen Corps, a national network of volunteers dedicated to ensuring hometown security. Citizen Corps, along with the Corporation for National and Community Service and the Peace Corps, are part of the President's USA Freedom Corps, which promotes volunteerism and service nationwide. As stated on the MRC website, the events of September 11, 2001, revealed a deficit in our nation's preparedness when many medical providers who wanted to help alleviate the strain on local medical systems where the terror incidents occurred arrived on their own and at personal risk. Despite their intentions, their presence became problematic for emergency managers due to difficulties that arose surrounding the use of spontaneous, unaffiliated volunteers. Issues such as credentialing, liability, and management rose to the forefront. The MRC provides the structure necessary to pre-identify, credential, train, and activate medical and public health volunteers. There are several state, legal, and regulatory issues related to disasters and public health emergencies. Neither this module nor the contents throughout this course should be construed as a legal interpretation of federal, state, or local law or regulations, or interpreted as allowing any given behavior by a health or medical professional. It is presented for the purpose of topical education and training in order to bring awareness of these important issues to the SMAT members completing the program. One important piece of legislation and regulation is the North Carolina Emergency Management Act of 1977, or Chapter 166A. The intent of this act is to set forth the authority and responsibility of the governor, state agencies, and local governments in prevention of, preparation for, response to, and recovery from natural or human-made disasters or hostile military or paramilitary action. The provisions of this act are set in motion after a proclamation of a state of disaster by the governor or by the General Assembly, or upon the activation of the state emergency response team in response to a disaster or emergency. Within those responsibilities, this act calls upon the governor, General Assembly, state agencies, and local governments to set in place capacity and capabilities to reduce vulnerability of people and property of this state to damage, injury, and loss of life and property, prepare for prompt and efficient rescue, care, and treatment of threatened or affected persons, provide for the rapid and orderly rehabilitation of persons and the restoration of property, provide for cooperation and coordination of activities relating to emergency and disaster mitigation, preparedness, response, and recovery among agencies and officials of this state and with similar agencies and officials of other states, with local and federal governments, with interstate organizations, and with other private and quasi-official organizations. This act also sets the jurisdictional boundaries at the level of the governing body of each individual county. It states that all emergency management efforts within a county are coordinated by the county and follows the axiom that all disasters are local. This act further directs that the counties will coordinate the voluntary registration of those residents with functional and or medical needs that place them as more vulnerable to the effects of a disaster. It further states that all information, records, and data concerning those functionally or medically fragile individuals be held confidential but be made available to the county emergency management structure. The North Carolina Emergency Management Act also addresses immunity and exemption issues for those identified as responders and acting in such roles in times of a disaster or state of emergency as declared by the Governor or General Assembly. This act states that all functions and activities relating to emergency management are declared to be governmental functions and, as such, are not liable for the death of or injury to persons or for damage to property as a result of any such activity, except in cases of willful misconduct, gross negligence, or bad faith. Of utmost importance to the SMRS, this act also defines the term emergency management worker to include any healthcare worker performing healthcare services as a member of a hospital-based or county-based state medical assistance team designated by the North Carolina Office of Emergency Medical Services, and any person performing emergency healthcare services under General Statute 90-12.2. The Act goes further to state that any member of a volunteer fire department, rescue squad, or emergency medical services agency who is called into the service of the state shall have the right to take leave without pay from his or her civilian employment. It further states that no member of a volunteer fire department, rescue squad, or emergency medical services agency shall be forced to use or exhaust his or her vacation or other accrued leave from his or her civilian employment for a period of active service. The choice of leave shall be solely within the discretion of the member. As an SMRS team member, it is incumbent upon the SMAT member to discuss availability with his or her employer and enlist their support prior to deployment. In April of 2001, the North Carolina Senate passed a bill, Senate Bill 160, and adopted in April of 2001 and recodified as the North Carolina General Statute 90-21.16, which was also known as the Volunteer Healthcare Professionals Liability Limitation. This bill extended the limitations of liability for anyone who, quote-unquote, volunteers to provide health care and emergency services. It also maintains liability insurance covering the acts and omissions of the free clinic and any liability pursuant to the subsection A of this section. The aim of this revision was to extend protection to those who volunteer their time and expertise rendering aid to the sick and injured for no payment. Nevertheless, this act does not protect against liability of damages from injury or death caused by errors or omissions based on the standard of care for those who function outside the boundaries of the standard of care that should have been provided by someone of equal medical credential. The Health Information Portability and Accountability Act, or HIPAA, was created with the intent to ensure an individual's personal health information remains protected and access to it is restricted specifically to those involved in the care of the patient, consulted for care of the patient, or in the conduct of business to bill for the services related to the care of the patient. It further provides options for who, on behalf of the patient, can discuss protected health care information. The HIPAA privacy rule is not suspended during a national or public health emergency. However, certain provisions of the rule can be waived by the U.S. Secretary of the Department of Health and Human Services during a national or public health emergency. These provisions of HIPAA may be suspended when and if the President of the United States declares an emergency or disaster, and concomitantly, the Secretary of Health and Human Services declares a public health emergency. If the above conditions are met, the Secretary of Health and Human Services may waive the sanctions and penalties against a covered healthcare system that does not comply with the following provisions of the HIPAA privacy rule. These include the requirements to maintain a patient's agreement to speak with family members or friends involved in the patient's care, the requirement to honor a request to opt out of the family directory, the requirement to distribute a notice of privacy practices, the patient's right to request privacy restrictions, the patient's right to request confidential communications. If the U.S. Secretary of Health and Human Services issues such a waiver, it only applies in the emergency area and for the emergency period identified in the Public Health Emergency Declaration, or to the hospitals that have instituted a disaster protocol. The waiver would apply to all patients at such hospital. The waiver would apply for 72 hours from the time the hospital implements its disaster protocol. When the presidential or secretarial declaration terminates, a hospital must then comply with all the requirements of the privacy policy for any patient still under its care, even if the 72 hours has not elapsed since implementation of its disaster protocol. Regardless of the activation of an emergency waiver, the HIPAA privacy rule permits disclosures for treatment purposes and certain disclosures to chartered disaster relief organizations such as the American Red Cross so it can notify family members of the patient's location. During Hurricane Katrina, HIPAA became a flashpoint in terms of sharing information, resulting in the Centers for Medicare and Medicaid Services issuing a memorandum that outlined the following points. Point number 1. Treatment. Healthcare providers can share patient information as necessary to provide treatment. Point number 2, notification. Healthcare providers can share patient information as necessary to identify, locate, and notify family members, guardians, or anyone else responsible for the individual's care, the individual's location, general condition, or death. Point number 3, imminent danger. Providers can share patient information with anyone as necessary to prevent or lessen a serious and imminent threat to the health and safety of a person or the public, consistent with applicable law and the provider's standards of ethical conduct. Point number 4, facility directory. Healthcare facilities maintaining a directory of patients can tell people who call or ask about the individuals whether the individual is at the facility, their location in the facility, and general condition. During Hurricane Katrina, the state of Mississippi, through the Emergency Management Assistance Compact, or EMAC, requested medical assistance from the state of North Carolina. The SMRS was activated and resulted in a multi-tiered emergency medical response. This EMAC response included resources from SMAT 2s and SMAT 3s from across the state, and the deployment of a hospital-owned mobile treatment asset. This mobilization was a success for the new SMRS and demonstrated that in addition to acute medical needs for victims of disasters, our nation's emergency health response was also not adequate to address the medical needs of the aging or disabled populations during a disaster. Following the post-event evaluation of the North Carolina Katrina response, the SMRS broadened its focus to include additional considerations for these populations. Federal funding permitted each region to substantially upgrade their SMAT mobility and field capabilities, which included the purchase of the Western Shelter tents, trailers, and additional specialized medical equipment. During the years that followed, evolution of the SMRS included an expansion of the SMAT concept with additional SMAT 3s. In addition, this expansion included the development of a state medical support shelter and the acquisition of additional warehouse space to manage large caches of medical equipment. In August of 2011, the SMRS responded to Hurricane Irene by opening its first state medical support shelter. The shelter was opened to receive medically fragile residents that had been evacuated from the coastal areas of North Carolina. The shelter remained open for approximately 1 week as a small, contained operation. However, despite the size of the operation, this gave the SMRS a chance to learn a lot of lessons about how a medical shelter mission works. Some of these lessons included the types of supplies needed, the types of beds needed, personnel needs, and the limitations of the SMRS as a whole. For the 18 months leading up to August 2012, the Metrolina Healthcare Preparedness Coalition and the North Carolina Office of EMS worked with local, state, and federal agencies to help plan for the 2012 Democratic National Convention in Charlotte. By the time of the event, support was required from SMRS personnel and equipment from across the state, including the Eastern Region SMAT 2, Mobile Disaster Hospital, and many others. For the DNC, the SMRS provided backup medical infrastructure support, which included establishing the Mobile Disaster Hospital as a responder treatment center or as a medical evacuation staging point, establishment and staffing of 3 care centers inside the hard zone, staging of ambulance strike teams and disaster medical specialist teams outside the metro area for immediate backup if needed. Also, 7 Western Shelter GK 1935 tents were set up inside the Metrolina warehouse to provide air-conditioned space to house many of the SMRS responders. This was another great chance to exercise the logistics and medical capabilities of the SMRS program with many lessons learned. In summary, the SMRS history, including that of the Office of EMS, a clear perspective of the SMAT types, registry, and operations integration has been presented. SMAT members should have a basic understanding of the legal, regulatory, and ethical issues that impact health and medical care delivery in deployed conditions, and how key North Carolina laws and regulations affect such operations. Knowledge of the key components of healthcare infrastructure and how they impact planning, roles, and responsibilities is important. The concept of casualty management in austere environments was introduced, as well as the key elements of public health in SMAT operations.